Good evening to all of you. Thank you for being here with us in the neuro-oncology meeting. And the first speaker is Professor Hui Gan, which is a medical oncologist. And he's working at the Olivia Newton-John Cancer Research Institute, Austin Hospital in Melbourne. And he is going to present current practice and controversies in neuro-oncology. Professor, the floor is yours.
So I'd like to thank the organizers again for inviting me to speak. And so I'm a medical oncologist at the Austin Hospital, and I treat head and neck and brain tumors. And I also have a lab group working with EGFR. And I'm just really going to talk today, is a sketching about the clinical environment, not more than that, and then perhaps just end on some questions that I think as a clinician might be useful for, questions that nuclear medicine could answer for us potentially. So brain tumors, I think that brain tumors are a devastating tumor that's been very much in the press recently. And the reason that's really a cancer with such terrible prognosis. And I'm just showing some data here from the Australian Health and Welfare Bureau. And you can see that brain tumors, although not very common, is actually have extremely poor survival. You can see that the 5-year survival there is just on 20%. And in fact, that probably includes lower grade tumors, for example. And if you then look on the right-hand side, you can see that there has been pretty much in the last 30 years, we've made very little, if any, improvement in the outcomes of these patients, whilst other tumors have been making large progress in terms of improving patient outcome. And unfortunately, it is rather a depressing tumor in that this is, again, looking at Australian data, where we look at the mortality impact that brain tumors has. And what you can see is not projecting very well, but in fact, if you look at on the right-hand panel for deaths in women, brain tumors are actually the leading cause of death, oncological death for young women below the age of 20. And in men on the left, it's sort of level pegging with leukemias. So it disproportionately affects young people, and even when it affects older people, the prognosis and the mortality is very high, unfortunately. So as a medical oncologist, I mean, brain tumors covers a whole spectrum of tumors, and I'm really only referring to primary brain tumors. I'm excluding sort of metastatic tumors from other cancer sites which are treated in my hospital by specialists in those areas. But with primary brain tumors, like as following the incidence that you can see there, much of the work that we do is in gliomas, astrocytomas, and glioblastoma, which is the most common kind, is what we really spend most of the time dealing with. So pretty much for this talk, I'm really going to be focusing on glioblastomas, but then talking about some of the lower grades as well. So what I do as a medical oncologist, essentially my work is almost all entirely based upon this seminal study by Roger Stupp about the use of concurrent temozolomide and adjuvant temozolomide with radiotherapy. And I'd like to say that this was probably, in my mind, the last major advance that has come out in neuro-oncology, and that was published in March of 2005, really. And just as a quick refresher, temozolomide. So temozolomide is a highly bioavailable chemotherapy drug. We always have to assure the patients that, in fact, temozolomide is a tablet, but it's a real chemotherapy. So it's well absorbed, and the other thing that makes it important is that it crosses the blood-brain barrier. So temozolomide belongs to the alkylating class of agents, and essentially it adds an alkyl group or methylguanine group to the O6-methylguanine, and in this way interferes with DNA replication, results in cell death. And this is what we call the Stupp protocol, which is what we do all the time. But to take you through it, so essentially this is in two parts. We meet patients when they've just had their surgery, and then we say to them that what they really need is to have 2 phases of treatment. And the first phase of treatment is that they let them recover for 2 to 4 weeks, and then they start on the concurrent chemoradiation phase. And we say to them, you're going to come in every day for 6 weeks to the hospital, Monday to Friday, and you're going to get a dose of radiotherapy. So it's 30 grays by 2 grays by 30 fractions. The temozolomide is given as an oral dose every day, including the weekends, which often causes some confusion because radiotherapy is only on weekdays. but you essentially do that for the 6 weeks that you're on treatment. By that stage, we give them a break of 4 weeks just so that they can recover, mainly from issues with fatigue and cumulative, perhaps some nausea. And then there starts the second phase where they just have the 6 months of temozolomide. And that's given at 5 days out of every 28. So that whole thing takes about 9 months thereabouts. And this is still our best treatment that we can give a patient who's got a newly diagnosed glioblastoma. You can see here from the Kaplan-Meier curves that although the reduction in death, the hazard ratio is 0.6 and it's well tolerated, if you actually look at where the curves end up at 5 years, it's really still not a great outcome. So if you get the chemoradiation, which is the best evidence-based treatment, the survival in a clinical trial was about 10%, really. So I think that obviously there's still much room to move from there. Now, I want to segue a little bit into MGMT, so methylguanine methyltransferase, because as you can see, that what happens is that the temozolomide essentially acts by adding an alkyl group, and this is the direct antagonist to that. So the MGMT actually removes that, so it's reversing the effects of the temozolomide. So we can see that where you have active MGMT, which is a suicide enzyme, it's reversing the activity of the temozolomide, and you get worse outcomes. But in approximately a third of our patients, you can see that in the bottom row there, that the MGMT is switched off. The promoter region is methylated, and not surprisingly, then those patients do better in the sense that they have a better response to the temozolomide. And what you can see that when you stratify patients by in this study looking at MGMT status, and you can see that the 4 lines are basically whether you got radiotherapy alone versus radiotherapy plus temozolomide, and then it's broken down by whether you're MGMT methylated or not. And what this somewhat complex graph goes to show you is that MGMT is both a prognostic and a predictive factor. So what you can say is that for whatever treatment you get, you always do better if you've got your MGMT is methylated. So it's prognostic. Independent of treatment, you always do better. However, if it's also predictive, because if you're MGMT methylated, then you're going to do much better with the addition of temozolomide. So it's probably one of our first bona fide biomarkers in glioblastoma. But the other reason I really wanted to focus on this, aside from, well, a couple more things. That all sounds well and good, in theory, but MGMT, for those of you who, are interested in that area, is actually quite a tricky, technically tricky thing to do, and there is a lot of debate about how's the best way to do it, and there are clearly some ways which are not the correct way to do it. So one thing is that although it's a great biomarker, it's actually a difficult biomarker, and in Australia, it's actually not widely available or only available in very limited circumstances. But the other reason I wanted to talk about MGMT was that whilst it's a good thing, MGMT does perhaps contribute to some of the problems that we as clinicians have in the clinic, and where hopefully nuclear medicine might be able to help us in the future. So this is really about the question of pseudoprogression. So pseudoprogression is a term that we use where patients, having gone through that Stupp chemotherapy where they've had their surgery, radiotherapy, temozolomide, then I mentioned we gave them the month's break, and at that point we do the restaging MRI. And what I actually say to all our patients is that MRI is not telling you whether you're doing well or not. That's the new line in the sand. That is what your treatment, your brain tumor looks like after radiotherapy, because in fact there's a pretty good chance that it's going to look worse due to the effects, predominantly of radiotherapy, but of the combination. And just for example, I show you there an example where you've got, that's not going to project very well, but on the left you can see that there's a patient who has a tumor, and thereafter, post-radiotherapy, that looks worse. In fact, that's actually quite mild. If the patient was, we really wouldn't worry too much about that. We would think that would be pseudoprogression. But I've seen some very, very florid cases of that. And to give you an idea of the scale of the problem, this is a paper that I think is very useful by Dr. Brandes, who was in JCO. And the key things to take from that are that at the end of chemoradiotherapy, half of patients, their MRIs will look worse. Now, that's radiological worsening. It doesn't mean that this is actually tumor. This could all be, in fact, that it's just changes from the radiation and the chemotherapy. And the problem is that the brain has a very limited number of ways in which it can respond to insults and injuries, which includes the treatments that we administer. Now, how this intersects with MGMT, of course, with the MGMT methylation, as I mentioned, actually makes the chemotherapy more effective. But unfortunately, it actually doubles the risk of having this pseudo-progression, this fake progression where the MRI looks worse, but actually the cancer is responding very, very well. And the problem that we have is that, we don't know. It's clinically, it's often radiologically completely indistinguishable. So if you have a patient in front of you and the MRI looks much worse, you have to decide whether, is this patient got true early progression, which is bad news, and I need to do something. I need to change treatment. I need to do something for them. Or are they actually, or in fact, is this oral treatment change, which is all very good, these patients do better, and do I just keep going, even though the MRI can look quite alarming sometimes, really? And so, there's a scale of the problem for us is that half of patients will have pseudoprogression, and if you are methylated, right, if you're more sensitive to temozolomide, the chances that you're going to be pseudoprogressing is actually almost 2/3, really. Whereas if you're unmethylated, it's 1/3. And that's really a big problem. It's something we talk about at our MDMs all the time. So, that's a big problem, even for patients who are truly responding. To move on, though, I don't want you to think, though, that pseudoprogression is, all patients basically have pseudoprogression, it's all good, because unfortunately, progression is almost inevitable, basically. And when you progress, it's not good. Treatment options are extremely limited. And so here, I've just put a selection of studies, and you can see that in the top couple of rows, that's what happens if you give a patient who's got recurrent cancer chemotherapy. Take any chemotherapy, it doesn't really matter. Lomustine is probably the accepted standard in this setting. And you can see that the number of patients who've got tumor shrinkage as a result of that, which is our gold standard for benefit, is single digits at best, basically. Now, over 90% of people will not have any benefit from that. So let's have a look. So I think that chemotherapy, a lot of people are very nihilistic about chemotherapy. I come from a center where I guess we're quite aggressive. We have 3 standard lines of chemotherapy that we give. But mostly people have looked for better treatments as well. And going back to the hallmarks of cancer, angiogenesis is a topic. Angiogenesis, so GBMs might morphologically look extremely vascular. It makes sense. Inhibiting angiogenesis would be beneficial. But that's actually been very controversial. This is one of those things where, depending on where you're born and raised and work, you believe or don't believe in anti-angiogenic treatment. Australians tend to be a bit of a conservative bunch. We're not huge fans of anti-angiogenic treatments like bevacizumab. But I think what we can say is that very clearly, that at least in terms of a radiological response, inhibiting VEGF and causing normalization of the tumor vasculature has benefits. There is usually a reduction in the size of enhancing disease, and often symptomatically patients can do a lot better. And sodium aflibercept are sort of small TKIs that do something similar. However, whether they actually help you live longer is highly debatable, really. And I said that kind of depends on what paradigm that you're coming from. I think that there have been a couple of failed studies in the first-line therapy, and I'm not going to show you, but there's also some equivocal data from the EORTC. My take on it would be that bevacizumab and these agents can have some symptomatic benefit. It is possible that they have some small survival benefit, but in an unselected population, and there's currently no biomarker to select, the benefits are small at best, basically. So where do we go from here? So I think that, aside from angiogenesis, I think that the other standout target for a drug therapy in glioblastoma is EGFR. And that's because EGFR, epidermal growth factor receptor, abnormalities of EGFR and its pathway are the most common abnormality in GBMs. The TCGA has done an amazing job in characterizing this to a genetic level. And EGFR is, just stands out head and shoulders as being an attractive target. However, I'm going to go back. As you can see, that initial studies of targeting EGFR with either naked antibodies or with small molecules have been spectacularly unsuccessful. Again, this is taking patients who are unselected, giving them the drug, and you can see that the objective response rate is no better than chemotherapy. It's in that order of single digits. So I think that this is where it's such a compelling target that we, who've been very interested in EGFR as a target and others, haven't given up on it. I think we're looking at the next wave of treatments against EGFR for GBM. And certainly this is work that we've been very involved in. So we think that you need to target not just EGFR that's everywhere in the body and gives you toxicity. We think you want to target specifically EGFR on cancer cells. And in GBM, it's actually possible because GBM is probably the one cancer and the one place in the body that you can get a particular EGFR mutant called EGFRv3. I won't bore you too much with the details, but suffice to say that it's a truncated form of EGFR. It can't bind the ligand, but despite this, it constitutively signals. It's switched on. It's just signaling, grow. And so it's only found on cancers, and it really drives cancer-type behavior. So what we've done is that we've created a monoclonal antibody that just targets EGFRv3 and not normal EGFR. So you essentially have none of the side effects of targeting normal EGFR. And based on this tumor specificity, we've decided that what the best way to do it is to do a double whammy approach. The antibody itself preclinically really inhibits cancers, particularly the express EGFRv3. But we've created, together with a pharma sort of company, we've worked with them to create an antibody drug conjugate. And that's just the concept there. You take an antibody, you stick only a few molecules of a very potent cytotoxic onto it. In this case, it was a tubulin poison called methyl monoorostatin F, MMAF, and that's been entered into clinical trials. So what happens is that it's like a Trojan horse. The antibody binds to this cancer cell, it gets taken in, and once it's inside, it's broken apart, and the chemotherapy drug is released and kills the cancer cells. So here you have an antibody that only binds the cancer cells and hopefully inhibits it, but it also delivers a chemotherapy only into the cancer cell and not normal tumors. So we did Australia led the phase 1 study of this. This is some rather oldish data. It was a slide that I had readily at hand. And what you can see is that in this phase 1 study, whether you gave the drug by itself, which are the orange bars, or together with temozolomide in green. Now, when I say with temozolomide, these were all patients who just failed temozolomide. So the temozolomide essentially kept going, and you added the drug to it. And what you can see is that on the far right, that really is not going to project, but yeah, you can see. So here are patients where the cancer has completely disappeared, really. And so overall, about 20 to 30% of patients had tumor response, which was amazing, really. This has since gone into a very large phase 2 study and through the AORTC in recurrent disease, where basically the drug is being compared to chemotherapy. Martin Vandenberg presented at SNO last year. The take-home message is that it missed out by just that much, in the sense that in the primary analysis, you can see that if you were on the blue bar, where you got the ABT414 plus chemo, versus the red bar in red, that your chances of being alive at 23 months were either, if you're on the ABT, 23%. If you were on just chemo, it was 0. But the p-value initially was 0.06, but on multivariate analysis, it's actually, I think, 0.001, something like that. So we're waiting for that result to read out later this year to see whether that becomes positive with longer follow-up and becomes registrational. But the hope is that really it's in the first-line setting, which the study is ongoing, that we think will read out in about 12 months or so. But why do I belabor that? I think that it illustrates 2 points, though, about where we're going to go if we're going to be using these sort of targeted agents. Firstly, the target has to be there, and that means that you need to have EGFR amplification or EGFRv3 that's there. So only about half of patients have this, and so far we've had to use archival tissue to test it. And that may not be the best because EGFR amplification is fairly stable, but EGFR-V3 is actually lost quite substantially. I think it's about half can lose it just because you've had radiation chemotherapy. So if you use tissue that you had before radiotherapy, it's probably an inaccurate guide. But getting more tissue for GBM patients is very tricky. So we need to perhaps have some non-invasive way of doing this, to have some sort of molecular phenotyping. The other problem, I think, with highly targeted agents is the questions of heterogeneity. And I think this slide is just meant to illustrate that you have heterogeneity at a spatial level throughout a tumor, and you have chronological heterogeneity over time as the tumor mutates. So again, needing some sort of way of being able to repeatedly assess tumors without always having to get tissue. Lastly, I wanted to just say that the other thing that was very interesting is that this drug may have unexpectedly have some immune effector function, and that therefore being able to assess for tumor-infiltrating lymphocytes may be very helpful. But again, we come down to the lack of tissue to be able to do that. But that's very exciting in terms of perhaps being able to combine this with immunotherapy, which have been not as successful in brain yet, but we still have hopes. So I'm sort of winding up to the last part. So I think that very briefly, I just want to touch on the lower grades of gliomas, astrocytomas. With the anaplastic, I think there's no the argument now that for these tumors, if you have certain molecular markers, particularly if you're 1p19q co-deleted with IDH1 mutation, that the evidence for adding concurrent chemoradiotherapy post-surgery is compelling. There were two different studies by the RTOG and the EORTC that did it slightly differently. You either gave the chemo before radiotherapy, after radiotherapy. It was also very old chemotherapy. And so this has fueled huge debate in the oncology community about, I like my PCB versus I like my temozolomide. So I think the principle that grade 3s should also get chemoradiotherapy is established. We can argue about what we think is the best chemotherapy. But I think increasingly what was, this is just the survival curve showing the very marked survival benefit. But I think that increasing the paradigm that we're having is that all gliomas, whatever their grade, probably would benefit from some form of chemoradiotherapy, essentially. And when Professor Buckner presented his study in low-grade glioma, I think the basic message, again, is that if you've got a high-risk grade 2 tumor, which is basically if you were sort of older or had a subtotal resection, you won't be surprised to know that in this randomized study between radiotherapy and radiotherapy plus chemotherapy, again using the older PCV regimen, that again there was a significant survival benefit for combination chemotherapy. So this leads to, I think, nearly the end. So where do I think? So that was just a very high-level sketch of the management of the most common malignant primary brain tumors. What are our difficulties that we face as clinicians? What are the opportunities? I think that if we look at glioblastoma grade 4s, I would say come back to this issue that we have very limited ability to characterize tumors with any sort of, we have limited ability to do it with any sophistication in terms of molecular targets, but I think increasingly physiological processes like vasculature and hypoxia are very important, but not something that we can do at this time. This problem of pseudoprogression is a real bugbear. It's a real clinical problem. And I think it actually impacts on patient survival because we're probably under-treating some patients and over-treating some patients. And probably given how bad the outcomes are, the ability to deliver treatments more efficiently must be an important thing. Certainly on the lower grades, I think that the optimal chemotherapy is an oncology thing to debate. But timing of treatment for long-lived tumors like this is a problem. And again, if we could perhaps be more targeted, that would be helpful. I think that sort of functional imaging can help us in all but perhaps the debate about chemotherapy. And I'm just very quickly going to finish up by saying that here's an example, again, coming from our lab where we think this is how functional imaging can help you. We return to the antibody we were talking about, which is tumor-specific. So we've shown here in animal models that you can use it to image tumors in mice, but we can also use it to image patients. and where it shows to be very specific targeted binding to tumors, but not normal tissue. It can be quantified, which is helpful for to see what the changes are over time. And using a slide that I showed earlier this morning, in anecdotal cases, it may also predict patients who are most likely to benefit from EGFR therapy. And I think that would also be relevant in, say, brain tumors, where perhaps one of our most promising agents is an anti-EGFR ADC that's in phase 3 testing. And that was where I was going to end. So thank you.
Thank you, Professor Gan, for your splendid presentation. Is there any question from the audience? Sure.
So I have a question. And I would love to work at the Olivia Newton-John Cancer Centre. What a great name.
We can arrange that. We can arrange that.
Yeah, okay. So I'm open to moving. The unmethylated patients, what's the evidence that the temozolomide does any good in that group of patients?
Well, I think if you look at the data, there is benefit. It's just lesser benefit, that's all. So I think that, that the evidence would suggest there is some minor benefit to them. And that, I think the other flip side of it, which is not a truly scientific answer, but is our answer in the clinic, is we don't have anything else. So,
thank you.
Thank you.
Thank you.
So I'd now like to introduce Professor Jun Hatazawa, who's going to speak to us today on neuro-oncology treating with the experts. I'll just flag that the Professor has to give a presentation next door immediately following this, so he won't be able to linger too long for questions afterwards.
Yeah.
Thank you.
Thank you very much, Mr. Chairman. Ladies and gentlemen, I'd like to talk about boron neutron capture therapy and fluorinating BPA PET study. The principle of boron neutron capture therapy is shown in the first slide. If the cancer cell include the boron 10 element, and if we give thermal neutron externally, the boron neutron nuclear reaction in the body create alpha particle and lithium particle. The travel length of alpha particle and lithium particle is very short, only 4 micrometer and 9 micrometer. And this is very high cell killing effect, like alpha radionuclide therapy. The BNCT is tumor cells targeted radiotherapy. It's just the combination of external radiation and internal radionuclide therapy. And we have the experience of this therapy using nuclear reactor as the neutron source for a long time, more than 20 years. And the accumulated data in Japan is almost 600 patients treated using boron neutron capture therapy. Now, the reactor-based neutron source is converted to accelerator production of neutron, and accelerator or cyclotron, it is now possible to install in the hospital. So at this moment, the patient don't need to go to nuclear reactor, but treated in the hospital. The BNCT is based on in vivo nuclear reaction between neutron and boron 10. Boron 10 delivery to cancer cells, and evaluation of how much boron 10 accumulating in the tissue using positron emission tomography. So 3 major points. How to produce neutron beam. It was a reactor, but nowadays it is accelerator. How to deliver boron 10 to cancer cell specifically, not to normal cells, is the next very important point. And third point is how to evaluate boron 10 accumulation in cancer and normal tissue before selecting this patient is appropriate for BNCT. We use this evaluation by positron emission tomography with fluorine 18 fluoroboronophenilalanine. Initially, the reactor, was used as the neutron source. We have the abundant neutron to the patient, but it is very difficult to take care of patient in the nuclear reactor because it is not the hospital. Sumitomo Heavy Industry of Japan developed the accelerator cyclotron, which can produce the neutron in the hospital. This is just the design of the cyclotron in the hospital for BNCT. The BNCT has the target here. First, the proton is accelerated by this system, just like production of FDG or other positron emitting radioisotope. The accelerated proton is coming to beryllium-9, and beryllium-9 proton reaction produces the neutron here. This neutron is going to the patient cancer site. Another very important technology for this therapy is purification of boron 10. As you know, the boron 10 and the boron 11 ratio in the natural state is 1:4. So boron 10 should be purified using some special system. The chemical separation was established by Stella Pharma of Japan. They succeeded in mass production of boron 10. As you know, the boron 10 is usually used for the radiation protection material against neutron. The delivery of boron to cancer is done in this way. This is the natural phenylalanine amino acid, a kind of amino acid. As you know, the amino acid is usually taken up by cancer. This is the boron, the phenylalanine derivative, including boron 10 here. This is boronophenylalanine. Before the boron BNCT, usually 30 grams of BPA is infused to the patient by drip infusion and bolus injection. We need to know the concentration of this ligand before neutron irradiation, because if the patient cancer did not have boron 10 in their cell, we cannot expect the good treatment effect. For that purpose, we created the fluorine 18 boronophenylalanine. This is FBPA using for the PET imaging to evaluate how much this tracer compound is located in cancer cell. Obviously, this compound and this compound is different. This is BPA, this is fluorine BPA. So first we have to do is similarity of this compound and this compound in the body. We examined the similarity of BPA and BPA in this way. First, we did the BPA PET study in small animals here, and after the imaging study, we give the therapeutic amount of BPA to the same rat. And after 1 hour, we sacrificed this animal, and we measure the boron 10 concentration using mass spectroscopy. And we compared count of the PET study and the absolute concentration of boron 10. The blue bar is the relative accumulation estimated by PET, and orange bar is the accumulation of boron 10 measured by spectroscopy. The blue and orange bar is similar. The brain, all these are normal tissue, and this is the tumor, transplanted tumor here. The relative accumulation of FBPA and boron 10 is similar. We confirmed in the animal study using glioma cell line. Recently, the Watabe et al. In my department confirmed the FBPA is specifically transported into the cancer cell by L-type amino acid transporter 1, RAT1 system. See, this is the FDG PET study of the transplanted tumor. This is the inflammation. The FDG accumulates to tumor and the inflammation. This is methionine. Methionine showed the high accumulation in tumor, but not in inflammation. FBPA is very similar to methionine. High accumulation in the tumor and small accumulation in the inflammation. And our in vitro study indicated the almost 100% of FBPA is transported by LAT1 transporter. Methionine is transported 50% is by LAT1 transporter, and 50% is LAT2 transporter. As you know, the L-type amino acid transporter 1, RAT1, is specifically expressed on the cancer cell in humans. We confirmed that RAT1 expressed in astrocytoma, glioblastoma, head and neck cancer, lung cancer, breast cancer, gastric cancer, esophageal, colon, hepatocellular carcinoma, biliary cell carcinoma. Major cancer cell express LAT1 transporter in humans. So, Protein 18 BPA is very good marker of the cancer diagnosis using PET. At the same time, we confirmed the specific delivery to the cancer cell of BPA and FBPA. This is the whole body FBPA PET in normal volunteer. Just after the injection, the tracer is excreted from the kidney, but no significant accumulation in the brain, liver, pancreas, no significant accumulation in normal volunteer. And the important point in this therapy is to avoid the tissue damage of normal cell. The previous study indicated if the boron concentration less than 20 ppm, the tissue damage is very little. And based on the PET study, we can calculate we can predict the boron 10 concentration based on this equation. If we know the BPA dose administered and the PET count and the specific activity of the FBPA, we can calculate the concentration in the tissue. Normal tissue showed less than 20 ppm, but the tumor showed the higher concentration of FBPA and BPA. This is the FBPA PET image in patient with brain tumor, glioblastoma. Maybe you can see the MR image here, enhanced one here, and high accumulation of FBPA here, and no other significant accumulation in the body. Then this is the very good candidate of PNCT therapy. Not only brain tumor, this therapy is applicable to many cancers, like malignant melanoma. The metastatic malignant melanoma is found in the lung here. This patient is also a good candidate of PNCT. This patient showed the CT abnormality here after conventional radiotherapy. This patient, in this patient, it is difficult to differentiate tumor recurrence or radiation necrosis using CT, MRI. And this patient showed low accumulation of FBPA in the brain here, and calculated concentration of FBPA and BPA was less than 20 ppm. So this is not the good candidate for BNCT. We are now conducting the phase 2 clinical trial of BNCT for brain tumors and head and neck cancers. We already completed the 20 patients, and now it is the observation period for 1 year to confirm any side effect after BNCT therapy. This is very early stage BNCT therapy for head and neck cancer patient. This patient had surgery, chemotherapy, and external radiation therapy, but we cannot treat this patient very well. So before BNCT, the patient showed in this big tumor here in the left side of the face. This is 1 month after BNCT therapy. This is 10 months after second BNCT therapy. And this is the 5 months after third BNCT therapy. It is almost disappeared, the cancer. Interestingly, the biopsy showed very little change of normal skin in this patient. This is patient with malignant melanoma on the foot, and you can see the malignant melanoma before therapy, and after therapy, all these cancer cells disappeared. This study, this therapy was done based on the reactor period, not the accelerator period. But now we can treat these patients in the hospital. This is another patient of glioblastoma. Before the BNCT study, you may find the tumor mass here. But 2 days after BNCT, this enhanced tumor is almost disappeared. So sometimes the effect is very rapid. This is reactor-based BNCT therapy and prognosis for brain tumor patient, glioblastoma patient. This was reported in 2009, so the accumulated data is during 2000 to 2007. Without BNCT, the 50% survival is almost 1 year or less than 1 year. But after introduction of BNCT, we have some long survivor after BNCT. This is only BNCT, no combination with chemotherapy at this time, because good anti-cancer drug was not yet delivered at this time. This is the case of malignant meningioma. The patient had BNCT, and the tumor size decreased in this way. This is malignant pleural mesothelioma, showing very thick lesion here. After BNCT, you can see the very thin tumor at this moment. So the therapy, BNCT is very new therapy using neutron irradiation, and we combined the neutron irradiation with fluorinating fluoroboronophenylalanin PET study to select appropriate patient of the study and to evaluate the normal tissue accumulation using before the therapy. So BNCT is a combination of external neutron radiation and radionuclide therapy, which is produced in vivo after irradiation of neutron. Microscopic local invasion can be treated by molecular basis of tumor, not by CT-MRI-based radiation. BNCT by the first in-hospital accelerator is now in phase 2 clinical trial for head and neck cancer and glioblastoma. We have already completed the registration and we give the treatment. Now we are in the observation period. New compounds for Boron 10 delivery. Evaluation of radiation dose, appropriate radiation planning, biological effect on normal tissue. Adjuvant therapy using a new type of chemo anti-cancer drug remain developed. Thank you very much for your attention.
So you have a few minutes for a couple of quick questions. So I'll open the session for questions now.
Thank you, Professor Hatazawa, for your very interesting presentation. I just wondered that we have a very interesting addition in the treatment of oncologic patients, and but specifically for patients with glioblastoma. You think that the response to therapy in comparison to standard techniques, it's much better, and how this can be translated in cost effectiveness of this technique?
Yes. The first point, I just showed very old data, reactor-based data for glioblastoma patients. But recently, the anti-cancer drug for brain tumor, just shown the previous speaker, is applicable for in combination with BNCT. We have more effective. We know that BNCT is more effective if it is combined with current anti-cancer drug. We can extend the survival much more. That's the first point. And the cost of the treatment, we need the special accelerator, cyclotron, for this treatment. It costs almost $40 million for all the, including the building and cyclotron. It is much less expensive than proton therapy or heavy ion therapy. So and of course, this is not only for the brain tumor, but many other intractable cancers. So we don't need this facility, many in the country, but this we can manage this one for the central cancer center. It is, I think, the hope of the patient, of the cancer patient, I think.
So,
yeah.
So thank you for that. Can I just clarify? So, can any cyclotron produce the boron? It's the neutron that needs special building.
Yes. You know, we have many accelerator cyclotron for the PET tracer. The PET tracer cyclotron is just for the production of radio, for example, fluorine-18. We need more and more abundant neutron for the cancer. So maybe we need high current cyclotron. Usually the cyclotron for PET tracer is 10 to 30 micro ampere, but the cyclotron for this therapy, we need milliampere current for the abundant neutron production. So this is a little bit different type of cyclotron.
Thank you.
Have you looked at all at whether some of the other standard amino acid traces are just as predictive of?
Yes. Yeah. We need the specific delivery to the cancer. For example, the methionine. Methionine accumulates to the normal tissue and cancer. So if we put the boron into the methionine, and it is not good idea. I think we confirmed it. The boron, methionine accumulates to the cancer at the same time in the, for example, liver or pancreas, or the salivary gland. So if we use this one for the delivery of boron-10, we cannot irradiate the head and neck or abdomen because of the unexpected side effect after neutron irradiation. So at this moment, if we use the amino acid derivative compounds, the BPA is the best one we have at this moment. But in future, we need more and more high concentration boron-10 in the cancer cell. So we are still trying to find such high delivery of boron-10. Thank you very much for your comment.
I think we'll have to let Professor Hatazawa go now. So thank you.
Thank you.
Introduce Ross.
Next speaker is Professor Rosalind Francis, nuclear medicine specialist from Sir Charles Gardner Hospital and University Western Australia, and he's presenting the PET imaging in glioma. Professor, the floor is yours.
Thank you, and thank you for the opportunity to speak today. It has been a long day, but I think you'd all agree, a very interesting program, so thank you for staying to the very end. I'm going to take you on a bit of a whirlwind tour of what is happening in PET in neuro-oncology. I'll just see if I can make the slides move. Okay. So this is what I'll be talking about, a little bit of a background to start with, including I think Hugh has covered most about primary brain tumours, but just some of the challenges of imaging in neuro-oncology. I'm going to really focus most of my talk on PET in neuro-oncology and talk a little about future directions. So I think, as we have heard, and I'm sure you're aware, glioma, it is the most common primary brain tumour in adults, and in particular, as we've heard, high-grade glioma is associated with a very poor prognosis, but is the most common type of primary brain tumour. Huey covered very well about the treatments that are currently used and the MGMT methylation status. And again, that on relapse, therapeutic options are incredibly poor. What I wanted to talk about was the imaging of glioma, but in particular high-grade glioma. So MRI imaging is the gold standard imaging modality, and it has multiple roles, and the clinicians are very dependent on MRI imaging in managing patients. And the roles include at diagnosis or staging, treatment planning, so planning in particular radiotherapy fields, response to therapy, and disease monitoring for relapse. There are unfortunately limitations, though, in the MRI assessment of disease, and these include assessing the extent of biologically active tumour, looking at intumoral heterogeneity that we've talked about. And in particular in the post-treatment setting, actually assessment on MRI is very challenging because of the balance between radiation, necrosis and recurrence. And again, as we have mentioned, pseudoprogression is a real challenge in clinical management of patients. So for MRI, the T1 weighted MRI images with gadolinium reflect areas of blood-brain barrier disruption. So it is important that you acquire T2 and FLAIR sequences so that you can also assess non-enhancing tumour. And I think as you can see here, these are the areas of gadolinium enhancement, which are very well seen, and they do represent breakdown in blood-brain barrier. So again, as has been well covered, pseudoprogression occurs in a variable number of patients on temozolomide-based regimes and is usually in that first 1 to 3 months post-completion of chemoradiotherapy. So characteristically, you do get an enhancement in MRI gadolinium signal, and as we've said, there are significant implications for patients' care. And I won't cover the work that has already been covered. But because of some of these limitations, there are new criteria that have been developed in MRI imaging to try and address some of these limitations. These are the response assessment in neuro-oncology working group criteria, and they were published in 2010. And they aim to address issues that are challenging, including pseudoprogression, including the antivascular agents who often have a rapid reduction in gadolinium enhancement, but that does not always correlate with a disease response. And that contrast enhancement is non-specific and not always a marker of true response, so it is important to look at the non-enhancing tumour. So these are the criteria as they were published, and it brings into play that there are multiple areas in terms of the sequence and multiple criteria that are required in order to classify response. And so not only is the T1 gadolinium enhancing disease assessed, but also the T2 FLAIR non-enhancing disease, the presence of new lesions, and also how the clinical status of the patient is taken into these response criteria, including corticosteroid use, whether patients are on stable doses or requiring increasing doses, and the clinical status of a patient. So often this assessment of progression is incredibly hard in the clinical environment, and often it is sometimes made in retrospect as you see progressive changes on MRI. But this is very difficult if you're managing a patient and you have the patient in front of you. And the other reality is, and it is often told to us by our neuroradiologists, is that the MRI scan often has a combination of post-treatment change and then probably a proportion of tumour, because as we've heard, it is very difficult to cure these patients. So you are dealing with what is the predominant effect? Is it post-tumour change or is it tumour recurrence? And there is significant implications for the patient. So really the focus of this talk is on PET in neuro-oncology, and we live in a fantastic age of where these PET traces really very much reflect molecular processes, and we have options. And this article published in 2010 I think is always been one of my favourites for showing what we're actually doing with the images that we see. These are reflecting biological processes. So in terms of neuro-oncology, there is the standard tracer of FDG, which we will talk about, but FDG activity reflects upregulation of GLUT transporters and hexokinase activity. There are the amino acid agents, which reflect, as we've heard, amino acid transporter upregulation, and there's also options including looking at proliferation with FLT. But there are also a whole range of other pathways that are potential targets. And not only is it the cell itself, it's the fact the cell sits within a microenvironment, and these are also potential targets for imaging as well. So we're probably just very much scratching the surface of the potential of what we can do in understanding the cellular process and imaging. So just to talk about what is more commonly used in terms of the PET agents in neuro-oncology, FDG PET in glioma is well known about. In low-grade glioma, you will often see actually quite low-grade activity similar to white matter. High-grade glioma, it's a higher grade activity, but the problem with FDG PET is the background brain activity. So brain is obviously dependent on glucose activity, and it does make interpretation difficult. So glioma was the first oncological application of FDG PET, and there is a correlation with tumour grade, cell density and survival, and FDG activity is increased in malignancy and inflammation. In Australia, we have a rebate for this, but I would say it is not commonly used. And that is because the reality is the high background brain activity makes interpretation extremely difficult. So we need to ask, what is the potential of new traces? I would say the new tracer that initially had quite a lot of excitement was FLT PET. So FLT is a thymidine analogue, and uptake reflects thymidine kinase 1 activity or DNA synthesis. FLT does not cross the blood-brain barrier, or it doesn't cross an intact blood-brain barrier. So it has low sensitivity in low-grade tumours, which usually have an intact blood-brain barrier, but high sensitivity in high-grade tumours and a correlation with Ki-67 activity. Increased intensity correlates with a poor prognosis. It corresponds very well to gadolinium enhancement on MRI because both are reflecting a disruption in the blood-brain barrier. And these are images acquired in our department when we were studying FLT PET in patients with high-grade glioma. You can see the MRI image with the white area showing the gadolinium enhancement. This is an FLT PET CT, and again, the FLT has a very similar distribution, and you can see the very low background activity. So the disruption occurs in the blood-brain barrier, and then the tumour retains FLT activity, and that is what correlates with the tumour grade and Ki-67 activity. A lot of the initial excitement around FLT corresponded to the antivascular drug therapies, particularly bevacizumab, and these were some of the trials that came out and publications. And it was showing that an FLT response very early post-treatment predicted survival, and a lack of response was associated with a poor prognosis. And this attracted really a lot of interest, but unfortunately I think the story is pretty much that the FLT was very much reflecting the blood-brain barrier response to the antivascular agent rather than necessarily a tumour response. So if you get a switching off of the leakiness of the blood-brain barrier, then the FLT can't actually get taken up into tumour. So it probably was not telling the whole story. And again, on our trial, we were imaging patients with both FLT and C11 methionine. And this particular patient, a young patient receiving the combination of an antivascular agent and temozolomide, had an MRI that looked pretty good, and an FLT that we thought also looked fantastic, but the C11 methionine at the same time actually showed a focal area of activity shown here in the subtraction images. And unfortunately, this patient in fact rapidly succumbed to their disease. And this, I think, was the case that was happening, that it was turning out that the FLT was maybe giving some false reassurance. So you were preventing the vascular effects of leakage of the blood-brain barrier, but not necessarily tumour response. So I think there's some work still to be done in that area. So most of my talk I will actually focus on amino acid PET imaging, because this actually is a tracer showing enormous promise in primary brain tumours. And this is based on the fact that protein synthesis and amino acid transport is upregulated in malignancy. FET is the commonest tracer used, and the predominant method of accumulation is via transporter upregulation. And FET is not incorporated into protein or metabolised after cellular uptake. Amino acid PET imaging agents do cross an intact blood-brain barrier, so there is background activity in normal brain. This is both good and bad, as we will see. So the three commonest agents that are used are C11 methionine. This is only really suitable for people with an on-site cyclotron due to the short half-life of carbon-11. As I said, F18 fluoroethyltyrosine, FET, is probably the most commonly used, and particularly in Europe. This is a relatively straightforward synthesis. And fluorodopa also is a very good amino acid brain tracer. It has a more complex synthesis, but it is used more often in the US. And the only thing is that the fluorodopa is obviously taken up into basal ganglia, because it's also used as an assessment for movement disorders. That is problematic if you have a tumour in that particular area, but otherwise it is a very good imaging agent. This is a fairly standard FET PET imaging protocol. Patients are usually asked to fast for 4 hours. They receive a standard dose of FET and usually put in a head holder for immobilisation on the camera. Most sites will inject patients under a camera, and it's not uncommon to do an initial dynamic phase imaging followed by a static phase imaging. This is fairly standard images that you acquire, which are very good quality, and usually it's pretty reasonable lesion to background ratio in areas of tumour. So in this case, a transaxial slice with the CT and the PET, and this in the coronal view. And this was post-resection in a patient, showing that even post-resection you can actually have significant areas of residual tumour. So with amino acid PET, uptake occurs in both high-grade and low-grade glioma. The intensity of uptake is not always correlated with tumour grade, as there are some low-grade gliomas that can have quite intense FET activity. So what is the evidence, or what studies have been performed with amino acid PET? A lot of the work initially was around lesion detection and diagnosis, and there's actually been a systematic review and meta-analysis of this published a few years ago now. And the data that was included in the meta-analysis was 13 studies of 462 patients, and these meta-analysis showed that FET-PET has high diagnostic accuracy in detecting primary brain tumours and differentiating them from benign brain lesions, with a pooled sensitivity of 82%, specificity 76%, positive likelihood ratio 3.4, negative likelihood ratio 0.24. And because there is background activity in normal brain, they also looked at what is the tumour to background ratio max, so that is the SUV max in the lesion compared to the background average counts in normal brain. What is the kind of limit that would differentiate likelihood of tumour from non-tumour? And that looked to be around about the 2.1 level. And that had the best diagnostic value. Just to show that this is a summary from the paper of what patients were used to look at in the meta-analysis, I guess to say that not uncommon for some of our nuclear medicine studies. Most of these were all predominantly single-site studies of around 20, 30, 40 patients, some a little bit more. But I did want to highlight also that in terms of the imaging protocol, although the imaging of the static phase was in most people around that 20 to 40 minute mark, there was actually substantial variation in each study on exactly how the imaging was acquired. But in this study, they included the patients that had histological verification. So in terms of detecting a malignant lesion, amino acid PET looks very good, and there is a meta-analysis quality publication on it. In terms of tumour grade and prognosis, characteristically amino acid uptake is higher in the higher grade tumours, but that is not 100% the case. There is some data looking at kinetic patterns of activity, particularly in that early phase of imaging, and just looking at a simple time activity curve might be able to improve your accuracy of tumour grading. And generally with the better prognosis tumours, there is a slow rising accumulation curve, whereas in the more high-grade tumours, there's fairly a rapid accumulation and then a little bit of a washout. And that may reflect a breakdown in blood-brain barrier or accessibility, but it is a fairly typical pattern that is seen. And the pattern of the time activity curve has been shown to correlate with prognosis in the lower grade gliomas. This is what I mean by the time activity curve from a publication in 2015, and just showing that in this case this was this rapid increase and slower sort of downsloping side of the curve. This kind of pattern is actually associated with a worse prognosis, seen here in the solid line with a shorter time to peak, compared to here where there is a time activity curve that is a slower rising curve, and these patients actually have a better prognosis in terms of time to progression and overall survival. So the way that the FET activity is accumulated into tumour does appear to be prognostic. So what are some other prognostic features of FET PET? And certainly what seems to be important is the volume of tumour that you're defining of FET PET. And this is particularly in the case of post-debulking surgery. And in this particular study, there were 44 patients assessed post-debulking surgery prior to radiotherapy, and they found that if you have a larger amount of residual tumour post-surgery as defined on the FET PET study, then you have a worse prognosis. And in this particular study, the gadolinium MRI-derived volume was not as significant. So again, the larger volume of residual tumour has a poorer overall survival and disease-free survival, reflecting the residual volume post-surgery and the difficulties of treatment. And I'm just highlighting, I guess from now on, you'll see that I've put in green, this is a single centre prospective study, and as we go through this, I have tried to indicate most of these studies are in fact single centre as we go through. And again, so another single centre study, this time retrospective, again assessing biological tumour volume post-op prior to radiotherapy planning, again showing in the post-operative setting the burden of disease seems to be important for prognosis. What about radiotherapy planning? Can FET-PET help us in this particular setting? And again, there has been a number of predominantly single-centre studies published in this, and it does appear that amino acid PET imaging is complementary to MRI for assessing extent of high-grade glioma and for planning therapy. And generally, the studies are showing that if you incorporate FET-PET in addition to the MRI, in fact, the radiotherapy planning field will often be changed, and in most cases, it's often larger. And studies have shown that if you compare what you would have planned with MRI compared to FET-PET, that in a number of cases, the FET-PET activity falls outside the MRI field. And there's a couple of papers that reflect that. That's, reflecting the field is telling you one thing, but is it actually important? Unfortunately, in high-grade glioma, this is actually quite difficult to assess because most of the recurrences that actually occur in field. So you have targeted it with radiotherapy, but unfortunately the radiotherapy is not completely effective. And that does make assessing patterns of recurrence difficult. But the provisional work that has gone on in this is suggesting that, in fact, most recurrences do occur in that overlap of MRI and FET volumes. And about 20% of recurrences occur in sites that would have been missed if you'd only used the MRI in planning and you hadn't used FET. As we talked about, MGMT methylation is important in this disease, and interestingly, these patients tend to have more non-central recurrence. So it may be that the combined radiotherapy chemotherapy is working better in them. They're not getting the central recurrence, but they are more prone to non-central recurrence. And this is clearly an area which requires further research, and it will be very useful to know how FET-PET can influence radiotherapy planning. Intuitively, if it seems like it would be useful. There are some studies looking at predicting response to chemotherapy. Again, a single-centre study showing that an early response to chemotherapy with FET-PET appears to predict outcome. These were just done very shortly after completion of treatment or a little bit later. And again, there was some provisional evidence to say that a response appears better than no response. Again, somewhat intuitive, but quite useful to know. And then in terms of tumour recurrence and pseudoprogression, which we've talked about is actually a huge clinical problem, it does appear that all of these agents are very useful in this setting. Bearing in mind that low levels of activity do reflect post-treatment change, but higher levels of activity or higher SUV maxes or tumour to background ratio are more likely to predict tumour. So in this particular paper that was published a couple of years ago in 22 patients with suspected recurrence, they found that a tumour to background ratio or a lesion to background ratio of 2.3 predicted whether there was progression or pseudoprogression. So low-level changes of FET activity appear related to post-treatment changes, but once you have more intense activity or tumour to background ratios greater than about that 2.3 level, it is more likely to be in keeping with actually progression of disease, and that is also related to survival. Again, there does seem to be some interest in the dynamic imaging with a time activity curve, with these patterns of the peak also reflecting the likelihood of disease versus a pseudoprogression. So I just went wrong. So in this particular case, this is just the images from the published article. So in this patient who had MRI changes following chemoradiotherapy, they then had an FET PET scan performed. There was not very much FET activity, and this is in fact the curve that was seen in the time activity curve, which is fairly slow rising, so they felt pretty confident that was just post-treatment change. Whereas in this particular one, with quite a lot more intense FET activity and also this time activity curve pattern of an early peak, this was more in keeping with tumour progression. So I think these are very promising tools that certainly look as though it may help in the interpretation of the MRI changes. So I just wanted to talk about the summary of evidence for amino acid PET. So there is certainly significant emerging evidence of utility of amino acid PET in a wide range of areas in the management of primary brain tumours. And the potential clinical utility includes lesion detection, prognosis, to guide radiotherapy planning, and to differentiate true progression from pseudo-progression, which is a big clinical problem. But I would say that the issue is the published studies to date, although numerous, are almost all single centre, small patient numbers, and are frequently retrospective. And this is a real problem in terms of evidence base. So there was a paper published just a few years ago, which is the RANO working group and European Association of Neuro-Oncology recommendations. And they actually say the major obstacle for the widespread use of amino acid PET in glioma patients is the limited reimbursement, despite the fact that current data clearly favours amino acid PET. So the fact that there's no reimbursement means there's limited availability. But unfortunately, across all traces, there are such numerous studies that have differed in terms of methodology, which has limited comparability of data. And this is probably, again, an obstacle to getting these agents through the regulatory system. The guideline that they published, however, is very supportive of using amino acid PET, and they felt that this would add additional value to MRI in glioma management, and that further clinical studies should definitely consider the use of amino acid PET as an imaging modality for glioma. So I think that they are saying that it looks highly promising. It certainly appears to be definitely better than FDG PET, but there is a need for evidence. So just to finish off and talk about future directions, I just wanted to touch on the importance, and I think this whole situation of amino acid PET imaging in neuro-oncology is one of these areas which are important, and the importance of multi-centre clinical trials. So multi-centre clinical trials in imaging are increasingly important for establishing clinical impact on imaging on patient management decisions and clinical care. We're now being asked to provide that evidence in order to get these traces funded by our regional funding bodies. And funding and regulatory bodies require data on safety, test performance, how the imaging test may influence patient management, clinical outcomes and economic analysis. And it falls on us to acquire this data and provide this evidence. So conducting multi-centre clinical trials in imaging is, however, challenging. There's obviously individual site variations in PET cameras and imaging protocols, and these must be standardised. There are complexities in data analysis. Recruitment of patients depends on collaboration with your clinical teams, because we're not the ones referring the patients, we're actually receiving the patients for imaging. And there are actually limited funding opportunities. And so trials networks can be something that can support multi-centre clinical trials, because they can provide a method for harmonisation of imaging protocols, they can assist in centralised data review, they can form linkages with other trials groups, particularly clinically, to help in trial design to make sure it's clinically relevant, and ensuring promotion of the study to their referrer group and patient recruitment, and also to create leverage for funding opportunities. So just to touch on, so in Australia we have a trials network in nuclear medicine called ARTNet, or the Australasian Radiopharmaceutical Trials Network, which is a joint venture of our professional societies, launched just 4 years ago, but it has a mission statement of promoting and facilitating innovative collaborative clinical research using radiopharmaceuticals for imaging or therapy. I am the scientific chair, so I do have a vested interest in it, but I would encourage people to visit our website or email if you're interested. We are always looking for collaboration and sharing ideas as well. But since the initiation of that particular trials group, we have been successful in multiple multi-million-dollar funding of clinical trials. We have 2 running in prostate cancer. You probably heard about it at the meeting. But recent funding success by Professor Andrew Scott and a multitude of investigators across Australia in a project looking at FET PET in a multi-centre clinical trial setting. And I think from my talk you can see how necessary this kind of trial really is. This was a funding application to our government and was recently approved, and is in collaboration with our radiation oncology trials group and with a clinical oncology trials group with a special interest in brain tumours. So the aims of this study to assess if initial staging FET-PET is an independent prognostic indicator of patient outcomes, to look and see whether information from FET-PET can improve targeting of radiotherapy fields by delineating unresected disease, and in the post-therapy setting to assess if FET-PET can differentiate tumour recurrence from disease progression or pseudo-progression. These are three really clinically important questions that will be assessed in a multi-centre prospective clinical trial, and hopefully we can report back at some stage with the results of that study. So I just wanted to finish off by saying, and I think we touched on earlier, the importance of biomarkers. So there's increasing recognition of the interplay between systemic biomarkers and imaging features in tumour. As we've said, in high-grade glioma, MGMT gene promoter methylation is associated with responsiveness, outcomes, and also likelihood of changes on imaging, such as pseudoprogression. So if we're designing imaging trials, it is critically important we're also taking into account biomarkers which have an interplay with our imaging studies. If you can design studies of imaging, it is really important to enrich those studies by incorporating biomarkers. As our understanding of this area increases, it will be incredibly useful. So I'm just going to say thank you again for staying. It was very good of you all. And I very much acknowledge the staff that I work with and the work that has been put in and the trials units. And also in Australia, really, the nuclear medicine departments have had enormous generosity and willingness to work together. And I think this is the next phase of nuclear medicine, so we can start generating this data, which will hopefully have the ultimate aim of improving patient care and outcomes. Thank you.
Thank you, Professor Francis, for your excellent presentation. Is there any question?
I think I want to go.
Yeah.
Can I ask a quick question, Darryl? How important do you think is to have a full 40 minutes of dynamic imaging? Can you truncate that and still get most of the information you need?
Yeah, so I think, probably the first 20 minutes is the dynamic phase, and then you just need a static phase, which could be from 20 to 30 minutes or 20 to 40 minutes. As I say, everyone seems to be doing it slightly differently. It does look as though that kind of period for your static acquisition is the important time, and the dynamic is a bit of a bonus in that we seem to be getting some additional information from it. So there's just a heterogeneity in the publications. Some people just do static, some are doing combined dynamic and static, some are doing complex kinetic analysis. We will certainly in the trial provide a protocol that we think will be applicable clinically, but get the maximum information in a clinical trial setting. But we hope at the end of that we could recommend a reasonably simple protocol that could be followed at sites, because it needs to be applicable. If it's too hard, it won't be able to be done.
So we do a 30-minute dynamic and just reframe the last 10 minutes of the statics.
Yeah, and that's what most people would end up doing. That's exactly right. So the cameras can easily do that.
You think among the FET and the FDOPA, which you think is the more promising as an agent?
I think both appear very good in particularly high-grade glioma. FET has a simpler synthesis, so probably going to be cheaper, and it is simpler to adopt at multiple sites because of that. And the other thing is the basal ganglia activity at FDOPA does make that area more difficult to assess if you have an adjacent tumour. So it's fine if you have cortical-based tumours, but perhaps not quite so easy to interpret that. But we've generally found we do synthesize both FDOPA and FET, but FET is a simpler synthesis, so it does seem like a good agent.
You said that it's probably difficult to differentiate between high and low-grade gliomas?
Just that some low-grade gliomas have quite high intensity of activity, so it's not necessarily determining grade to that extent, but just to be aware that some of the lower grade ones do still have quite high activity. But certainly in the initial post-surgical setting, it seems the volume of residual tumour is highly prognostic, even more so than just necessarily the intensity.
I think we have one last question.
Not entirely sure. Did you mention that you're working on a multi-center trial? When do you expect those outcomes?
So we're funded. We got the announcement 3 months ago, is it? So we hope by the end of the year that we would be recruiting patients. It's actually a 5-year funding, but the outcomes in high-grade glioma come pretty quickly. So that is one somewhat unfortunate thing about the disease. It has such a short prognosis. So it's going to take a couple of years to get those results out, but they will come. Various aspects will be answered earlier than other aspects, to be honest. So I think we will recruit reasonably quickly because we have very interested and motivated sites across Australia. So once each site is set up and ready to recruit, our experience has shown that we can recruit relatively quickly, certainly in the prostate trials, and these patients really do need better treatment. So I think we could recruit reasonably quickly.
Thank you. I think we'll close the session at that point. Enjoy your evening, and thank you, Ross.